your question about sequencing is relevant, and I think will remain relevant with or without a role, or with or without checkpoint inhibition upon progression, beyond progression, right? So, if you figured out that it's really not helpful for patients to get a PD-1 or PD-L1 after progression on a prior checkpoint inhibition, you still have other options you need to think of, right? You have to think about TKIs, probably between Cabo, LAV, TiVo, and AXI. Probably that's what we're going to be thinking. I think in a couple of years, we're going to have belzutifan as one of the first HIF-2 inhibitors that we will be using for sporadic aRCC. I think we might be start playing or understanding better the role of, radioligand therapy using renal overexpress targets, like CA9. So I think that's possible. And in the meantime, we might come up with antibody-drug conjugates in other approaches that we can think of that we're not quite obvious to play a role in the management of advanced RCC in the future. So, so between the TKIs available today and maybe a HIF-2 inhibitor available and maybe another therapy, if not more than one, right? You already have a big question about how we're going to sequence that, right? So that's probably where I think we're going to go. At the same time, I think we're going to make a lot of progress regarding the molecular profiling and how that can help us with patient selection, and I think as we start including molecular profiling in the randomized trials, we're going to start understanding a bit better who gets what. So I think we're going to make progress there. And instead of just going by clinical or disease characteristics, right? And maybe novel imaging would also open the door for an opportunity about local therapy that we haven't, we do think about it, but we might think about it a little bit different, right? Because novel imaging, will allow us higher sensitivity to detect probably, earlier progression, right? And that might change a little bit how we manage those patients, especially in the context of radiosurgery, which offers very high rates of local control, different from conventional radiation therapy, and sometimes also, local therapy, including local resections, right? So that is already being done currently, but we're based off, conventional scans to do that. And I think novel imaging has the potential to change the way we offer metastasis-directed therapy, and the way we do it in other tumors such as prostate cancer. So as you can see, I think the discussion about how we're going to manage advanced RCC in the next 5-10 years, I think it goes beyond the access to novel therapies, which obviously they will be available based on clinical benefit. But I think it involves other components such as, again, molecular biomarkers, novel imaging, right? And perhaps, who knows, novel prognostic scores, predictive and prognostic scores that might take all this into consideration instead of going by labs and clinical factors. That's kind of what we're doing right now, right? Which basically what IMDC, takes, or a Sloan scores, take right now to kind of fit our patient into a bucket of a good risk or good risk of, intermediate or poor risk categories.